Uh, my name my name is Dr. Joyfrida Chepchumba, and I work for the Ministry of Health under the National Cancer Control Program. I'm a program officer in charge of the third pillar in the program, and the third pillar is called cancer treatment, palliative care, and survivorship. And so I'll be a moderator for the day, and I'm really honored to have this opportunity to handle this very vital discussion on palliative care and survivorship for our patients. And we are going to hear from a good team of experts in this topic. We are going to have David Musyoki, who's a palliative care nurse and who has been working at KEPCA, which is the Kenya Hospitals and Palliative Care Association. And he's currently the executive director, so he's very well versed on palliative care for the past 18 years. And so he's going to be our first speaker. We are also going to hear from Dr. Wanja Mutura, who is a dedicated clinical and radiation oncologist practicing in Garissa County. Her work centers on delivering high-quality cancer care grounded in evidence-based medicine and robust, good clinical practice principles. Dr. Wanja has a strong commitment to integrating comprehensive palliative care into her oncology practice to ensure holistic patient support. And to have a real life experience on this topic, we are going to have Jennifer Mwema, who is the CEO of Jennifer Cancer Foundation. She's a cervical cancer survivor and advocate. So our panelists, you're much welcome. Without much further ado, we are going to start with David Musyoki, who's going to take us through palliative care and why it's an important discussion. David, you can unmute and continue. Thank you.
Okay, thank you very much, Dr. Joyfrida, for the introduction and for the opportunity that we have to have a short sharing on the subject palliative care across disease trajectory. I've been introduced, and my talk today, the next few minutes, will be on integrating palliative care into cervical cancer management, pain and symptom management, and also psychosocial support. And I hope I'm audible. So I work for KEPCA, and KEPCA is the umbrella body for palliative care, which coordinates palliative care, and we work with Ministry of Health, stakeholders in health, and we're happy that there's been quite some good progress matters integration of palliative care in the Kenyan spaces. So in my presentation today, I will cover the principles of palliative care from diagnosis, assessment and management of pain in brief, and more specifically looking at cervical cancer, issues around mental health, overview, and then the need for support for caregivers, and then the need for linkage and referrals for patients with palliative care needs and their families. For purposes of ensuring that we all are on the same page, what palliative care means, WHO gives the comprehensive definition of palliative care, and it's quite a mouthful, or it's very elaborate. It's an approach that improves the quality of life for patients and their families. It's an approach that addresses life-threatening conditions or illnesses. And how palliative care works is through prevention and relief of suffering, And this prevention and relief of suffering happens properly when we do early and impeccable assessment and treatment of pain and the symptoms that patients have. And remember, these symptoms are not only physical, they are also psychosocial and spiritual. In brief, if you may not be able to remember the whole definition, palliative care is support given to patients and families faced with hard to cure conditions so that those patients and the families have comfortable lives or their quality of life is improved. So that keen even to cover the aspect that I talked about. Look at this case scenario of Mary, who is 34 years, with advanced cervical cancer, and she has severe pain. She has full discharge. She bleeds sometimes and experiences incontinence because she has a fistula. She's 4 months pregnant and very distressed. Based on her level, she experiences quite some stigma and is at the verge of losing her job because of the condition that she has. Her family is strained. She's even getting depressed. And financially, she's not good because she's used quite her savings to her treatment and seeking support from the condition that she has. And her symptoms talked about full smelly discharge and the bleeding, the incontinence is causing some effects to her spouse and the children as well. She comes to your facility or she comes to a center that provides palliative care for holistic care, and she hopes that she can be treated successfully so that she's able to survive and continue to be supported. Thinking about this case scenario, for us to be able to address Mary's quality of life, we have to think about these four key dimensions that have been floated by Farrell, the great scholar, palliative care scholar. So think about palliative care and think about addressing quality of life from the four key domains, which include physical support. Remember, she's having discharge. How do we fix that? She's having severe pain. How do we manage her pain? She's having incontinence. How do we ensure she's, her quality of life and her life is good? She's at the verge of depression. That's psychological. How do we support Mary so that she gets out of the depressive state that she is in? We talked about having some issues with the spouse, sexuality issues. So could be psychological and could also be social. We talked about her financial state and loss of job and all that, together with the stigma that she is facing, could be social related or even psychological. And then there is this big pillar here, spirituality. What gives meaning to life? When she asks herself sometimes tough questions, why me at 34? And why now? What happens to my children in the event I transition from non-survivorship to end of life? Those tough questions. So for us to address Mary's concerns and to support her based on her situation, we have to think through all these domains. And as healthcare workers who provide support and care to patients in need, for us to say we are addressing quality of life properly at optimal levels, we have to think about all these domains. So when we fix the pain using pharmacological, say for example, approaches, do we also fix these other things? And therefore, In principle, when Mary comes to our clinics or comes to our levels of care, we have to think about the holistic support to her. And we say assessment always precedes treatment. So proper assessment with pain assessment tools and the other tools that should be used to do assessment, they become very key. Uh, when we're doing assessment, then we're able to set realistic goals. And the goals could be treatment goals and life goals. We're able to monitor the responses to the specific interventions that we have put in place. And through impeccable assessment, we are able to communicate effectively and efficiently to the satisfaction of the client, not to the satisfaction of us as the carers. This is where we are keen to ensure that we get feedback based on our communication. Did our communication really hit home? Or did we say things and left the room, leaving the patient more confused than they were? And it happens in many clinical setups. So in palliative care, we are very keen to ensure that whatever we communicate is based on the level of the patient or the receiver's understanding, and as well that we elicit and get feedback so that we are sure that our communication uh, was complete. And then symptom management is really key in terms of as a general principle. More specifically around pain, uh, it takes a whole session to talk about pain assessment, but for purposes of just outlining this in a palliative care setup, it's good to think about the type and the source of pain. Mary would have, pain because of the disease process. She would have neuropathic pain because probably the neuropathic or the nervous pathways have been affected. We have to think about the severity of the pain and how the pain presents, and score it, in scales of 0 to 10, and then we qualify it. If it's mild, then it guides us to how we treat it. If it's moderate, then that guides us to how we treat it. And if it's severe, how do we treat it? And remember, it's not only physical pain, but there are other kinds of pain. There are associated symptoms to the pain, because if somebody is bleeding and they have discharge, it just worsens or exacerbates the physical pain that they have. Again, how does the disease process affect mobility? How does the pain affect sleep, other activities of daily living, including sexuality? How does Mary relate with the spouse who probably, and we've had patients say that their cervical cancer diagnosis or presentation was worsened by their spouses demanding, for their conjugal rights. So how does that, affect their pain or their assessment? Sometimes even not necessarily the whole aspect around sex, but also how do they view themselves? Do they look at themselves as a complete human being? Do they look at themselves as a complete woman based on their condition and their situation? So in assessment, you want to find out all that. And then that guides us to how do we manage that pain? If it's physical pain, utilization of the WHO step ladder in terms of pain management, of course, with addition of adjuvants, and then other approaches that would support Mary. Does she need radiotherapy or some surgery, depending on her status? And therefore, now, as you do this, remember palliative care starts from diagnosis so that we provide the holistic care. And therefore, palliative care should be an integral part of our management. When you're thinking about mental support or psychosocial support, definitely she's anxious, she's depressed, she's thinking how the diagnosis is affecting her, daily life, body changes, fertility concerns. If she needed to have a child or other children, how does she go about that? There's the whole anxiety that is brought by the fear of eventualities and the stigma associated with that. So how do we support the patient? Again, remember the support, psychosocial support here would entail education, giving proper information, family counseling so that there is support from the spouse and the children and the people around her. Emotional support, where we say we listen more and speak less so that we are able to support Mary, and sometimes even connecting her to psychologists or professional counselors is key in terms of provision of that psychosocial support. We talked about the need for caregivers, be it healthcare workers or caregivers in a home setup, would include family members or guardians or people that are close to Mary. At times it becomes very difficult for them to manage. And sometimes the conditions, especially cervical cancer in advanced stages, gives quite a strain in terms of daily support to that patient. So they may experience burnout. The financial strain would make it worse for the patient. The support that is needed for the children and the spouse in terms of providing proper information and walking the journey with them. And the palliative care providers would provide, group support where they bring people that have more or less common conditions together, and they are talked to or given information as a group. The hospices have what we call daycares, organized psychosocial support groups, where they come together and they are taken through different sessions. They could include what the diagnosis is all about, what it entails to, provide care in a daily for patients who would require such. And even we saw the on the case that she faces a tough situation where she may be losing her job. That becomes a big thing. It's a human right issue. So again, supporting employers or being the advocate for Mary so that the employer is considerate, probably giving her lighter duties depending on her level of managing, allowing her sometimes day offs, especially when they have to go to hospital, and being accommodative enough vis-a-vis also making business based on those levels. So palliative care must be holistic. And when we talk about holistic care, we're saying from the point a diagnosis is made, teamwork and multidisciplinary approaches are key. You realize, based on what I've said, not one professional, be it the doctor, be it the clinical officer, be it the nurse, be it the physio person, be it the social worker, alone could be able to provide a holistic, comprehensive care. And so my emphasis today is that palliative care should be holistic, and the holistic support can only be provided by a team. This includes home-based care support, which is key. Many people associate palliative care with end-of-life care, but I just wanted to clarify here that end-of-life care is part of palliative care. Palliative care is not equated to end-of-life care. And so we say we prepare and we support patients, and even those who are facing end-of-life or who are at imminent points of death. And even those, we provide more support and care to them by being available and providing quality of life at such phases. People are given treatment, support, and they are cured, or at least they are stabilized enough, and they come back as survivors. So survivorship, and I know somebody will talk about that at length, so that there is proper rehabilitation and reintegration into the society and into the community, and people experiencing full life. So as I conclude, for us to be able to link patients properly through the KEPCA's website, and through this link, you will find all the palliative care providers in Kenya and the contact details. In case you're stuck, feel free to reach out to KEPCA. Finally, our recommendation as an association and from our point of view is palliative care should be fully integrated into oncology care and in all disciplines, as long as patients have life-threatening conditions. There should be consistent access to essential palliative care medicines. Again, community health promoters need to be empowered so that there is timely and proper referrals. Early provision of palliative care services is key, and as we provide support, being culturally sensitive is a must. Allow me to invite all of us to the 7th National Palliative Care Conference, where discussions like this and much more will be at length. It is happening on the 25th to the 27th of February, and in Mombasa. More information, please find it on our KEPCA website. Thank you for your audience. Back to Joy Frida.
Thank you. Thank you so much, David. And also thank you for demystifying that palliative care is not just end-of-life care, it's more than that, and it needs to be integrated right from diagnosis. Because we all know this cancer journey is quite a scary journey, and the patient needs support all the way from when they get the diagnosis to just really improve their quality of life, whatever the outcome that they may finally get. So thank you so much. And I hope we all register for the conference. It will be later on this month. So please remember to put any questions or any thoughts and the Q&A. We'll address them at the end of the session. So up next, Dr. Wanja will take the floor and just guide us through survivorship, because we know cancer is not a death sentence. We have very many survivors. Even when we know sometimes we lose some of our patients, we still have some who really survive, and years later, they're here to speak to us. Even Jennifer is on the call. She's going to take us through her survivorship journey. So, Dr. Wanja, you can take the floor. Do you have a presentation? Dr. Wanja? Okay, let's give her a minute. Meanwhile, please put any questions, any comments. Maybe tell us the facility that you're representing. Do you have palliative care in your facility? Do you refer your patients to palliative care? Are you a palliative care specialist? Kindly put in the Q&A or in the chat. Just a minute as we trace Dr. Anja.
Next, please. So in terms of surgical related complications, these are dependent on the extent of the surgery, and the potential complications that may arise include, but not limited to, the following, where a patient might develop adhesions. There might be associated long-term abdominal pain. They may present with small bowel obstruction. They might as well present with urinary dysfunction, for example, incontinence. Gastrointestinal complications, for example, diarrhea. They might also present with pelvic floor dysfunction, which may manifest by a variety of urinary, bowel, or sexual effects, as well as lymphedema. In relation to chemotherapy-related complications, these ones may vary, and this is dependent on the regimen that is used, whether it is part of a multimodal treatment regimen, which means that we are combining different treatment modalities in treating cervical cancer, or if we use it as a single modality. And the types of complications include neurotoxicity, cardiac toxicity, cognitive dysfunction, what we usually call term as a chemobrain, increased risk of developing hematological malignancies such as leukemia. This is usually several years after treatment. In relation to radiotherapy-related complications, we have the long-term complications that include fibrosis of skin or subcutaneous tissue. This means the region where we treat, it develops into something very firm or hard that is not consistent with the other soft tissues or the skin. They might also present with vaginal stenosis, which really affects their quality of life, especially when we talk about their sexuality or intimacy. They may also present with vulvovaginal atrophy disease, for example, in stage 3B as well as 4A. There's also increased risk of developing cancers of the skin, subcutaneous tissue, and underlying organs. And a common malignancy that is associated as a result of radiotherapy is sarcomas. But of note, it is a small percentage, so that's why we need to follow up these patients to be able to ensure that we are able to monitor and detect early. There's also a risk of developing premature ovarian failure, particularly when we administer radiotherapy, and also the risk of developing uterine atrophy, particularly associated with radiotherapy. So in terms of immunotherapy-related complications, immunotherapy is currently the new kid on the block. And as a result of that, we don't have substantive data to be able to extrapolate the long-term effects of this treatment. So currently, what we know is that they are efficacious in terms of controlling locally or advanced cervical cancer. But in terms of knowing their long-term effects, these studies are currently ongoing. Next, please. So in relation to our topic where we're discussing survivorship, we have to consider what we've been able to do for our patient. So survivorship does not begin after completion of treatment, but this is a discussion or a plan that needs to be initiated once we start treating this patient, so that we are able to institute measures to ensure that in relation to long-term effects, that we are able to counsel the patient and institute measures to ensure that we minimize the long-term effects of the treatment. So following completion of treatments, patients should receive regular general medical care, and this is guided by the recommended guidelines and patient characteristics. So our primary focus is usually the in relation to managing chronic disease, and for example, depression, diabetes, hypertension. This might be as a result of the comorbidities presenting when the patient presents to us, or factors like depression, which is associated with the psychosocial aspect of the treatment, as well as just the significant or the burden of just the diagnosis as well as the treatment journey. Then we also want to be vigilant in terms of monitoring cardiovascular risk factors. This is as a result of the different modalities that we employ. And also we do recommend vaccination, because remember, the region where we are treating this patient is an important part in terms of immunity, and this is in relation to the radiotherapy that we administer. And we know that we need to monitor these patients because of the risk of immunosuppression, one, as a result of the disease, second, as a result of the treatment that we administer. And lastly, we also want to encourage adoption of healthy lifestyles, that is promoting exercises. And for those patients who indulge, for example, in smoking and alcohol, we would like to counsel them to stop, so that we ensure that in terms of their survivorship, we reduce the risk of developing comorbidities in the event that they are absent, and as well as considering nutritional counseling through the treatment course as well as post-treatment. So in terms of the follow-up schedule, after we complete treatment, this is broken down in a time series. So the first 2 years after treatment completion, we would like to review this patient at a 3-monthly interval. And in cases where we have geographical limitations, we would like to review this patient every 6 months. But in cases where, for example, this is locally advanced disease, this is a patient who has a higher risk of recurrence. So we would like to ensure that we have a closer monitoring time interval compared to patients with early disease stages. And after completing 2 years, we would, for the next 3 to 5 years, we would increase the time interval of review to 6 monthly or 12 monthly, depending on the patient characteristics. And thereafter, we would want to monitor for the next at least 5 years, review this patient every year. And the investigations that we would like to conduct during these reviews, we want to ensure that at least every year we have a cervical or vaginal cytology. When I mention about cervical cytology, remember when you're dealing with early stages disease, let's say stage 1A to 1B1, these are patients who we try and preserve the uterus as well as part of the cervix. So you might find that you still have cervical tissue in within or in situ. So you still want to ensure that there's no development of cervical cancer. And in cases whereby you have a patient has undergone a hysterectomy, so this is a patient who you would want to do a vaginal cytology. And the imaging modality of choice is dependent on the stage at presentation. Next. So in terms of late effect surveillance, the aim is to assess the late and long-term effects, and we need to have a comprehensive documentation of the following. One is the patient history, which includes the treatment history, the comorbidities before treatment initiation. We need also to have detailed toxicity experience during treatment, because this in itself is an indicator of the probability or the severity of the late effects that the patient might develop, and also the type of treatment modalities employed. So in relation to the kind of radiotherapy, for example, that we may administer, we can anticipate the kind of toxicity or the late effects that might develop. When a patient comes again, we also want to do a thorough physical exam, one, to ensure that we are able to look out for the late effects. Second, as a modality of surveillance, to ensure that in case the cervical cancer recurs, we're able to detect it early enough. And just to ensure that we also are able to advise and counsel the patient to improve the quality of life of this patient. In terms of also the surveillance, there's the post-treatment imaging, as we said earlier, that is related to the stage at presentation, as well as laboratory testing. And here we are looking at just the normal physiological process, where we look at the full hemogram just to check the HB level, the WBC. We also want to look at the renal functions of the patient because of the history, for example, of chemotherapy administration. We also want to look at the bone density of a patient, particularly for postmenopausal women, or if we have administered radiotherapy with the increased risk of inducing early menopause. You want to monitor the patient to ensure that they do not develop osteoporosis. Next, please. So, as my colleague had mentioned earlier, we don't manage the disease alone. Remember, the disease is in a patient. So we are managing the patient in terms of holistic care. So as we seek to ensure that 90% of our women who are diagnosed with cervical cancer get the appropriate treatment, we need to remember that the woman presenting to the healthcare system is more than a statistic. And this is an individual bearing different hats. So she is a mother, she might be a daughter or a wife, a professional, a sister, and a friend. So we need to look at her as a human being with needs besides just of getting a cure. So as such, we need to have her needs addressed in totality to be able to get good outcomes. And curing cancer, while curing cancer, we need to understand that when we lose her dignity, we have lost this battle. And this calls for integration of care, which entails incorporating different elements of care. And this one, we're talking about psychosocial, emotional, spiritual, as well as financial support. Next, please. And as we look about or think about holistic care approach, as my colleague has said, we're going to utilize the concepts of palliative care. So as he mentioned, palliative care should start at diagnosis so that we work with this patient from the word go, taking care of different components of this patient so that again, we improve the quality of life by addressing the physical needs of this patient, the psychosocial needs of this patient, the spiritual needs of this patient, and the emotional needs of this patient. And this can be achieved through multidisciplinary care approach that involves different speciality at the onset of treatment or diagnosis, so that again we have different tasks. We're able to adequately and effectively conduct our tasks. For example, the clinician is able to adequately treat this patient. The nursing is able to carry out her duties accordingly. We involve the psychologists and counselors as well as fellow patients so that they can be able to share their lived experiences to ensure that we're able to adequately manage this patient. Next. So in terms of this approach, it will be very significant to be able to facilitate social reintegration and also be able to redefine family roles and expectations. It will also provide mechanisms to support individuals becoming financially stable. And this is from an analysis that we were able to do at one of our leading referral hospitals, where we realized that majority of our patients presenting to our facilities are self-employed and most of them are subsistent. Their businesses just provide the daily needs. So when this patient stops working to be able to undergo treatment, you'll find they might face a lot of financial challenges. So when we manage this patient or approach this patient in a holistic manner, we're able to support this patient to be able to now come back on their feet and be able to be financially independent. So since these care components are beyond the scope of the clinical care team, working simultaneously with patient support groups and peer navigators will ensure patients are managed in totality. And these support systems complement the treatment plan through shared experiences, as well as offer critical support in the patient journey. So what will be the role of these survivor support groups as well as peer navigators? This can be broadly classified into patient-related as well as systemic-related. This list is not exhaustive, but just highlights the importance or the significance of these very important groups. So when we look at the system-related roles, they provide patient and consumer perspective. This is in relation to evaluating the efficacy of the delivered care, and they also offer insights that improve patient care. Just to elaborate on this point, as a clinician or as a healthcare worker, you might think you're addressing the needs of the patient, but when you get the feedback or the lived experience from the patient, you're able to custom or to be able to come up with a treatment plan that addresses the concerns of the patient. Because again, you're not just treating the cancer, but the cancer within the patient. So you're able to get the feedback and be able to custom or rather place the patient at the center of all the treatment plans or the policies and just the healthcare system to be focused on the patient care to improve good outcomes. Also, the peer navigators are instrumental in closing the gaps in care. This is through shared experiences. They serve as navigators, or they're able to assist patients to be able to navigate or rather to go through the treatment process and the healthcare system without being lost to follow-up. As we know, many of our patients do not stick to the treatment plan as prescribed because of various challenges. One, because they're not familiar with the healthcare system. So these peer navigators are very instrumental in ensuring that our patients know what is required of them and they comply to treatment. And these two groups are also instrumental in advocacy at different levels. This begins at the community level, where they're able to create awareness. They're able also to ensure that they minimize stigma through community awareness and education. They're also vital at the institutional level because they are a voice for the patient, and we are able now to engage at a different level to ensure that our patient get the care that is required. And as all of you have seen in our recent, in the media recently, they have been able to engage with the government to be able to inform policy and also to improve the healthcare system. So when we think about the patient-related roles, we look at the psychosocial or the emotional support. This is through shared experiences, because we say that you're empathetic when you really or truly have lived through a certain experience, because you can relate at a personal level. They also facilitate resource mobilization or treatment adherence. They also provide an avenue for debriefing or counseling. They provide practical advice and coping skills for their fellow patients. They also provide a community which aims to reduce isolation and also provides hope for the individual patient. They also provide empowerment and an avenue for advocacy. And they also provide information and signposting, and this aids to ensure that our patients adhere to treatment. And they also provide like a bridging the gap in terms of just healthcare workers and patients, because again, they have someone who's able to advocate for them, and also just to highlight what issues might be come around when we're managing these patients. So just a summary of what we've discussed. One thing we need to remember, that a woman is a complete being, that our treatment approach should be holistic, and that is from diagnostic to survivorship. Multidisciplinary approach to care increases efficiency. It improves both outcomes and the quality of life. Therefore, we need to work together, and we need to move from survivorship into thrivership, whereby our patients should not just survive this experience, but they should thrive through the treatment process into post-treatment. And cervical cancer is not a death sentence. So I want us to take us back to a Swahili saying that says kidole kimoja hakivunji chawa. So in direct translation, one finger cannot kill a louse. So together we can make a change. Thank you very much.
Thank you. Thank you so much, Dr. Wanja. That was very enlightening. Thank you for taking us through what our patients may experience during the treatment and after the treatment. and how we as healthcare workers can support them, the value of integrating the support groups. Thank you for that. You've actually set the stage for our next presenter, who's Jennifer Mwema, who will give us a lived experience. She's a cervical cancer thriver. I want to call her a thriver. And Jennifer, maybe you can unmute and just give us a brief of your story. When did you get diagnosed? How did you know there's a problem? How long did it take for the healthcare workers to pinpoint you to the right diagnosis? And how has the journey been during the treatment and post-treatment? And then, yeah, we'll continue from there. Thank you. Jennifer.
Thank you very much. I don't have a PowerPoint presentation since it's just my stories in my head. My name is Jennifer Moema. Jennifer is a teacher by profession. I'm even in school now. I'm in Coast. And Jennifer is a cervical cancer survivor. I say twice because there was a recurrence at some point. And I was diagnosed in 2014. In 2014, in Mombasa, I didn't know many people who had survived. And I would want to thank my doctor. I think she's here, Dr. Gita. She's the one who diagnosed me. And she was able to guide me very fast and told me you have to move very fast. I didn't know much about cervical cancer. At the time of diagnosis, I was told it was stage 2B. And I moved to Nairobi for treatment. And that is where I had my treatment for about 3 months. And I was told it's clear. That is back then, 2014. Then I came back to Mombasa. In 2014, I underwent through chemotherapy. I did the radiotherapy. And I also did something which was very painful called brachytherapy. I'm sorry to say that. Now, after that, I was told there was a remission. And after 3 years of follow-ups, there was a recurrence. And I started treatment again, which went for some time. That one was intense, which also shocked me. I shocked everybody who was around me. In the first diagnosis, I didn't tell many people. Why? Because of the stigma. I was fearing if they know, they will say that I'm dying. So I decided to keep quiet with my very close family members. After 7 months of intense treatment, I was able to be released to come back to work, which I did. But I continued with the follow-ups for several years. And currently, I thank God I'm doing well and I'm running my life the way it's supposed to be. And that is how the disease was. Then after that, after several years, I developed something which I up to now, I don't know what it is, but one of my legs usually suffers something like, not numbness, but when I went back to the doctor, I was told it is because of radiotherapy side effects. So I wanted to highlight that because somebody has talked about it, the side effects of radiotherapy. When I was approached, I was given some few things to discuss about. I think I should go that straight to that street. And the title of what I was given is Life After Cervical Cancer. So is there life after cervical cancer? Yes, it is. There is life after cervical cancer. But this life depends on several things. And one of them is how fast the treatment will be and at what stage the disease is caught. So early diagnosis will make the disease to be treated faster or early, and it will avoid so many side effects from my experience. And that means that you'll be a thriving survivor. You can be a survivor, but with so many issues. Then another thing is financial part of it. And this is what I would wish the medics, the Ministry of Health should underline very, very, very well. If the treatment is disturbing, if it is not, if the patient is mentally disturbed about the source of money, where will I get this? Where will I get this? You find that the mental health will be disrupted. And I remember that the doctor who was treating me told me that I should forget about everything else and focus on myself. But if there is no funding, if there is no money to go and pay for different drugs, that means there's no way I'll be able to focus on myself, or somebody will be able to focus on that. So life after cervical cancer, I'm sure depends on that. Other than all the other things, those two things are the core things. Now, under that, survivor stories can reduce fear and stigma. Yes, they can. And how do they do that? Because the messenger is the survivor, is the person who went through the disease. So most of the time, I've seen people creating awareness, but one part which is missing is the person who suffered from that particular disease. So if somebody is able to talk about cervical cancer and be able to say, yes, I went through it, being treated, suffering from cervical cancer or from any cancer takes time. So people see, the people around her, that person see, the people at the workplace see. So that means that if this person is able to come out and talk, people will be able to listen to that person, and that fear will disappear. And I can give an example very fast. A colleague of mine, the reason also I decided to come out so heavily. I'm usually very loud about cancer awareness. A colleague of mine in school staff from said, afadhali niwawe na kansa kuliko nipatikane nayo, sababu inafanya mtu akae vibaya kitambo akufe. And that person said that is a lady, and said that, and I was seated next to her. And that time I had not told them that I had gone through cervical cancer treatment. So from there, I was like, now, this now means that I need to talk. And I started. And those are the people who are able to come out and say, oh, but this thing is there. Others didn't even believe it exists. The same time is also the same place I got people who gave me a lot of stigma. And somebody told me to my face, we are going to give you a few lessons because we don't know how long we are going to be with you. So you find that it's true, the survivor stories will be there, will reduce the fear, but the stigma will always be there. But now this depends on how mental strength that person, or how much strength of the mind the survivor will be having. But if somebody decides to come out and give the story, I believe there are ways that person will be able to protect herself or himself when the stories on stigma comes. And remember, if somebody has survived, or if somebody has gone through the treatment, that person has seen it all, has gone through a lot. So nothing much will be able to affect that person. The other part which I was told to talk about is building survivorship programs, peer support groups, follow-up visits, and lively with support. Now, when you talk about building survivorship programs, we have what we call survivors groups. There are very many. But when you look at what goes on there, it's very minimal. It's about stories of how somebody suffered, et cetera, et cetera. It's like you console each other there. But now these programs should be in a way, okay, the way I see it, should be in a way such that people move from seeing cancer as that thing which is going to kill people, as that thing which is going to be very bad. Move from there. And because somebody has already survived, let that person have a program which is going to make that person feel like she did something, or she participated in something which should be positive, not something which almost killed. Okay, it almost killed that person, but people should not be made to feel like you should be there and remain there. You find that we have fragments of groups. We have the cervical cancer group, the breast cancer group, and the rest. So since I survived cervical cancer, during the treatment, when you go to the hospital, I was meeting people with breast cancer, with cervical cancer, with so many types of cancers in the same hospital. And my doctor encouraged me and told me, Jennifer, because you are a teacher, I know you can talk to people. And she started sending me people we share, because my treatment was very smooth. Other than the intensity of the effects of the drugs, everything else went well. And when we started talking, she could send me people's numbers, others come to me, we talk. And she was telling me that it's like your talking is different. Your talking is different. And I told her it is not different. It is because I'm the one who went through it. And somebody is able to see. I was able to document my treatment. I could take photos when I'm so down, when I have no hair, when the body is inflamed, so swollen on the face. So when I show somebody this is me and that person is like that, they are able to remember. So you find that some of these programs, they should be built in such a way that they encourage people to continue so that we are able to survive or to have these survivorship programs. So can it come from the government? Other than people coming just themselves together, can it come from the government? And how can we do that? Is it possible for I'm speaking using questions because I've not seen this one. Is it possible for the government to have a map of the survivors and what they do? Some of us, we are already working, so we are able to support ourselves. Others do not have jobs. Others, they even call and they will ask you for fare to go for checkups. I don't know where the money will come from, but I believe that can happen and people can be supported in a way. Because if you tell people that they're going to be in survivorship program and they're just put in groups, it will not work much. And the other thing I've seen in building successful survivorship programs is whereby in that particular group, there must be medics. People are able to tell people or to tell somebody when they ask questions, this is what to do. Because I see in most of the groups, you hear people asking others questions, somebody is answered by a fellow patient, and that's it. And it ends like that. So that is my take on that. The other part, we can build a successful survivorship is like personally now as Jennifer, what I did after surviving, I registered an NGO, Jennifer Cancer Foundation. And since 2019, I've always held meetings. It doesn't matter where, whether I'm in the gym, that is where we are going to meet. Whether I'm in the school setup, that is where we are going to meet. And particularly like last year, we met physically, face to face. I met with over 1,000 people to tell them about my story. But during this storytelling, we also bring in doctors, especially if it is during the month of breast cancer, we'll bring a breast cancer specialist who is going to talk about breast cancer, how it affects people, whom it affects, like that, just taking people through. Then the same duration, we've also done a lot. But remember, if we are going to have programs, it's not a master to incorporate, we bring only survivors. So that's why when we have to bring in other people. So for the programs to be successful, let us not only bring the survivors alone. Because if you bring only the sick ones alone, the whole meeting, if they sit down, the whole meeting will be about their history, their sad stories. But when you bring somebody else who is who is able to bring another side of the story, that will be able to bring also another direction. Then some of these programs, let them be built outside hospitals. And that again takes us now to the last point. Survivors can become advocates for HPV vaccination, screening, and early diagnosis and care. Since I started the Jennifer Cancer Foundation, I decided to take the screening away from the hospitals. I'm not a medic, but I know doctors. And I would wish to thank Coast General, Mombasa, Makadara, we call it like that. Anytime I approach the management, they always give me somebody to come and talk to, anybody I'm seated with. It doesn't matter the size of the crowd. Small crowd of 20 people, big crowd, they will always come. And this has brought a different dimension on what cancer is to the ladies I meet. I'm in the gym, we will sit down there and talk about HPV vaccination. Like last year alone, I was able to organize with my friends, and one of the cancer specialist doctors, and she was able to look for a place whereby over 60 ladies were able to do HPV testing. And that was the climax of everything. That one moved me. So why? And this was done in a gym setup. So I realized that when you tell people go to hospital to get the test, people are like, I will not go, I'm not sick. If you bring that somewhere else, the screening, let us demystify. Let us not take everything to the hospital. Let us take it somewhere else. Let's see how it will be. Personally, I've seen that. I went to Kitui. I took the screening in a church. So the other year, I took it in a school. So a church setup is different. So you tell them we are coming to church, we are going to have 1, 2, 3. And after that, the doctor will educate you. And if you want to be screened, come. We were able to screen over 200 people in the middle of interior. So let us take all this screening awareness outside the big towns, outside the areas we think people will come. Some people will not come. Remember, cancer, people believe. When we say cancer is not a death sentence, it is only me and you, the medic, who believes that. Out there, it is different. So people believe cancer is that big disease, that is a very bad one, and whereby if you get it, you're going to die. So they will not even come and ask you. It is you to go there. So where will you go? The majority are out there. Lastly but not the least, I saw something which the Minister of Health launched about eradicating cervical cancer. And when I saw it, I approached one of the doctors, and I told the doctor, what programs do you have? She's still going to give me the programs. But I felt like if we are going to eradicate cervical cancer, it's not about us who are grown-ups now. In 10 years to come, the girls who are 15 years, they'll be 25 years. The girls who are 30 years, they'll be 40. Those who are 10, they'll be 20. We are doing vaccination now. If we are doing vaccination now, we are only doing up to, if I'm not wrong, if it has gone much, maybe around 13, 14. So 15 years, 16 years, 17 years, 18 years, 19 years, that bracket of women has been left out. Why? There isn't much going on. I tried it last year, whereby I sat down some girls in the school I teach, it's a girls' school, and we were able to talk to them about this, and they don't know much. They don't know much about this disease. They don't know much about cervical cancer. They don't know. So it is the Minister of Health. Please come up with programs. If we want to eradicate cervical cancer, let us go down to these girls. Remember, there's a group which has not been vaccinated. The one which is going to be vaccinated, they're small girls. Then after that, what exactly are we going to do? Let us reduce the cancer, cervical cancer, by telling the right group, the 15-year-old, 16-year-old, 17-year-old, and then I believe that can take us far. Thank you very much for your time. I'm done.
Thank you. Thank you so much, Jennifer. And it's true, you really have a way of speaking that gets our attention and is really convincing. and we applaud you for the good job you're doing to even the advocacy work you're doing to have more people come for the screening, the vaccination for the girls. And yes, your message is home. I know the government programs that we have currently are for 10 to 14 years. That is the public program we have. The other ages, we do not have a government program, but I know the vaccines are still accessible to whatever age you need, but probably through the private sector. So I think for the government sector, they had to start with a cohort that they could manage first, and that's how they chose the 10 to 14 years. Okay, so we have 10 minutes to the end of the webinar. And I can see we have 2 questions. One from Joseph asking about a tracking system for palliative care that could flag those who've started palliative care and dropped off midway, maybe because of psychosocial support for a caregiver. David, what are your thoughts on this? Do we have such a tracking system? Would it be helpful?
Thank you so much, Yusuf, for the good question. And the palliative care providers in the country have tools, patient, tools that track number of patients and the patient's details who are under their care. And where there is good systems, there is also follow-up mechanisms. Where probably there are challenges in terms of follow-up, probably that's where we might find patients dropping off and there is no system through which they can be followed up. But in majority of the places, there will be at least some kind of follow-up, either through phone calls or through the community health promoters or volunteers who work closely with hospices and palliative care centers. So it would be very unfortunate that someone falls off the system or support and they are not being followed up. And probably if you have such a contact and depending on where you are at, we could link that patient for further care and support. Yeah, that's what I would say for now.
Okay, thank you. And I know through the cancer treatment centers, we also have a register for cancer treatment. And there's a column that actually tracks how many patients have been, like referred for palliative care. But unfortunately, it doesn't track past that. So it only collects the data on how many patients have been given various forms of treatment, including palliative care. But yeah, it would be helpful to track that. Okay. So the next question is about rehabilitation. Esther is asking, how do you modify rehabilitation goals when a cervical cancer patient transitions from curative to palliative care? I'm not sure that's the correct term, but I think we understand what she's asking. Dr. Wanja?
Kindly repeat the question.
So the question is on the rehabilitation goals when a cervical cancer patient transitions from curative goal to palliative goal. How do you modify the rehabilitation for such a patient?
So in terms of oncology care, the patient is always the center. And there's a movement in terms of how we address oncology care. So treatment plan is not, we might have guidelines that are standard across different countries and all that. But at the end of the day, you tailor the treatment in accordance to what you have in front of you. So from the very beginning, the treatment should be patient-centered. So one, what are the treatment goals that you're trying to achieve? Is it cure or is it improving the quality of life of this patient? And when we term it as improving the quality of life of a patient, these are cases whereby the patient, whatever treatment that we are giving this patient, we are not achieving cure. The goal is not cure, but is to ensure that the patient, we are managing the symptoms of this patient to ensure that the patient is as comfortable as possible. So what now the goals here would be working with this patient, trying to address the concerns of this patient. So as my colleague David mentioned, that you look at what the patient's major concern is. Is it the physical aspect, for example? Is she in pain? Is she having persistent discharge? So you try and address those concerns. And again, as you're managing this patient, remember we are social beings. So you're not just looking at this patient alone, but again, you're looking at the caregiver to ensure that, again, we do not have caregiver burnout, because once this caregiver gets burnout, you find that this patient will be adversely affected. So as you're managing this patient in terms of rehabilitation, one, you're trying to ensure that they are as independent as they can be, and if they are not in a position to be independent, you try and support the family to ensure that, one, they are able to address the needs of this patient through different, by introducing social workers and occupational therapists to be able now to teach them on how, for example, if this patient is bedridden or this patient is in a wheelchair, how best to manage this patient. And again, also taking care of this caregiver in terms of getting intermittent breaks in between so that they do not get fatigued, a term that we say compassion fatigue, so that in as much as this patient we are not curing, but the quality of life is good and that this patient is comfortable. I hope I've answered you.
Yes, Dr. Wanza, you've answered. And yeah, maybe David, you can just chime in. What are some of the components if the goal is not curative at that point? What are some of the components of end of life care that the palliative care team steps in to assist the patient and the family?
Thank you, Dr. Joy Frida, and thank you also, Dr. Wanja and Jennifer. You know, the content and what we're talking about is really aligning. And remember, we talked about the assessment, the impeccable assessment, which guides in terms of giving information and at the same time drawing realistic goals. Answering the question from the perspective of, uh, you know, transition, it's about walking the journey, and walking the journey entails many things. We had the testimony of Jennifer, our champion here, that she was diagnosed early. She was treated. The phase of that treatment was tough, as she says, but the goals of that care that time was cure, and it was effected. Unfortunately, there was remission. So again, the conversation that was there initially had to change because of the status at that point. And so for us in palliative care, it's about the care that we need to give now based on the situation now, whether it's curative, whether it's management, whether it's survivorship, whether it's end of life care, so that at any phase of life at that point for that individual, being the patient and being the family, we are able to agree on the goals of care and goals of support at that time. and therefore so that we are able to provide optimal care and optimal support for that individual. And that is why we say palliative care is very individualized. It's unique for me at such a time that I need that kind of care. So based on that, whether I'm in a phase of active treatment, there is a palliative care support that I need. When I'm in the phase of end of life care, I receive that optimum care at that phase. And in palliative care, we don't fear or run away from even end of life because it's a reality. And so preparation for that phase, much as it can be very draining and intense and not easy, we also prepare for it so that we have realistic goals and we give realistic hope, and we are able to walk the journey with that patient and family members at any phase, including preparation for death and even after death, what we call bereavement support, being very intentional to support patients based on their unique needs at that point. Thank you. I hope I've answered the question, Joy.
Yes. Thank you. Yes, it's actually very important that we handle the difficult conversations, and that is where the palliative care team comes in. We know the clinician may not have adequate time to sit and assess all the needs that the patient has, but we definitely can link the palliative care team to the patient and ensure that they get holistic support. So I'm seeing most of the questions have been answered. There's some questions about the cost of the HPV vaccine in the private sector. The estimates I have is around between 5,000 to 10,000, depending on the type of vaccine, depending on the manufacturer. You may find the different brands go for different prices. Someone is asking if they can get the vaccine. If a woman tests HPV negative, can she receive the HPV vaccine? I think that one you'll need to clarify with the doctor at the facility if that is possible. But yes, I think we've answered all the questions. So maybe just a parting shot from each of our panelists. We'll start with Jennifer. What I know we've ended the Cervical Cancer Awareness Month, but the advocacy continues. So what is your key message as a cervical cancer survivor?
Okay, my key message as a cervical cancer survivor is that early diagnosis will be able to save lives. And to the Minister of Health, let's take the screening and awareness to the grassroots. Let's move away from the towns. And also we should also demystify this disease. When you look around, an African woman, I call them secretive beings. They are very private. They don't talk much about themselves. So it is only somebody from out there who is going to wake them up. So I don't know if it is possible from the ministry, but if it is tried, it can help a lot. Thank you very much.
Thank you, Jennifer. Dr. Wanja, your parting shot on cervical cancer rehabilitation and survivorship.
I think for me, what we really need to do is work together, because together we can be able to make a difference. This is working together with our patients, working together with different cadres, with the ministry, just to have an open conversation on how we can make survivorship and improve our outcomes. So thank you very much.
Thank you, Dr. Wanja, and keep up the good work. I think someone was asking where you're based. You said you're at, maybe just clarify where you're based.
So I'm based in Garissa Regional Cancer Center. So it's one of the three regional centers that was set up by the government to offer comprehensive care. So karibuni sana Garissa.
Thank you. And I think that's one of the great fruits of decentralization of cancer care. Now we have patients receiving radiotherapy services in Garissa, and not just in one facility in Nairobi. We have Mombasa and Nakuru also offering radiotherapy. All right, David, could you give us your parting shot on this very important topic?
Thank you. Thank you, colleagues, for your audience and for the opportunity. I just want to relate with two observations, actually three. One is to applaud Jennifer for being so bold and sharing our own experiences. I pray that we can also be so bold to talk about our experiences, relating that to happenings that have today in the morning as I went through the streets of the city. There's a gentleman I saw with a placard saying cervical cancer month, end cancer. For me, that was a great highlight. And I said hi to him and I was like, keep going and don't be tired, And I looked at him holding that placard and I thought, okay, who would support his hands? Like the Bible context where, for us to win, we need support for each other, just to align with Wanja's call that we all do have a stake to play. And then there is a gentleman who is walking, I think, several days from Kitui to State House to deliver a huge mail saying, declare cancer a national disaster. Yeah, we know what it entails for disaster pronouncements, but that kind of push or advocacy from everybody and anybody out there is quite a thing. And so can we all join hands and do what we can do? Everybody can do something. And from palliative care perspective, our call is that we need to make palliative care as available as oxygen, so that access to anyone who needs palliative care, cancer care, health care should be available. So let's not be quiet and let's keep talking. God bless you. And again, welcome to the 7th Palliative Care Conference on the 25th February in Mombasa. Thank you. Bye-bye.
Thank you so much, David, and thank you for the good work that you're doing. So yes, my parting shot, I think, is just to remind us we have the targets to eliminate cervical cancer. So we have the 90, 70, 90 targets. And I hope all of us from this webinar would just pass on the message. We have over 600 people. So we need 90% of our girls to be vaccinated between 10 years. Currently, we're offering one single dose at any public facility, and it's free of charge. So the 11 to 14-year-olds who had not been vaccinated are also allowed to be vaccinated. But moving forward, we are only going to be giving to one age cohort, that is the 10-year-olds. The 70% is for the women to be screened. Kindly talk to your wife, to your sister, to your mother. We are screening all women between the ages of 25 to 49 years. And even beyond 49, if a woman has any symptoms and any problems, maybe pain during intercourse, maybe some bleeding, kindly let them go get checked immediately. The other 90% is the treatment that needs to be offered. When you go for screening, in case they find there are some lesions, they're called the precancerous lesions, they can actually be treated at that point so that they do not become cancer. So it is very important that 90% of women receive this treatment. So please, as we end the webinar, please remember 90, 70, 90 to eliminate cervical cancer. And other countries have actually done this. There are countries who have not reported a single case of cervical cancer because they vaccinated all their girls more than 20 years ago. So we can also do it. So for further information on the policy documents around this topic, you can visit www.nccp.or.ke. www.nccp.or.ke. You're going to find more documents there, the screening guidelines on which cancers should be screened, and using what methods, what is the age that should be screened using these different methods, the treatment protocols and guidelines that are there. You'll find all the necessary requirements there. Also, there's another very useful site called the MOH Virtual Academy, and you can get a course. There's a small simplified course there called the Early Diagnosis of Cancer for Primary Health Workers. It is simplified, and you can easily spot the various signs and symptoms, because many times we say these patients have been diagnosed late, but they came to your facility. This old man had constipation for over 1 year, but they kept on being given laxatives, and yet they could have been referred for a proper CT scan or a proper workup or histology, and the cancer could have been noted. So please, let's increase the screening and early detection of cancer and save lives. So thank you so much. My name is Dr. Jeffrida. Until next time, God bless. Bye-bye.